Hi, welcome to Elevate Your Energy Radio and Elevate Your Energy TV today because we are taping live in Nashville, Tennessee. I'm here with Dr. Mark Houston.
Hi, Evelyne.
Hi. So I'm your host, Evelyne Lambrecht from ElevateYourEnergy.com. I'm very excited to be able to bring you this interview that you can watch or listen to. So anyway, like I said, I'm here in Nashville. It is really, really cold. In fact, my hands are blue, which is not normal.
That's not good. That's Raynaud's phenomena, but we'll get that fixed, hopefully.
Yeah, I'm with a cardiologist, so hopefully we can take care of that. So anyway, let me read you Mark Houston's bio before I get into our questions. Mark Houston is Associate Clinical Professor of Medicine at Vanderbilt University School of Medicine. He is Director of the Hypertension Institute and Vascular Biology here at St. Thomas Hospital, where we're currently filming. He is on the faculty of the University of South Florida for the Functional and Metabolic Medicine Fellowship. He is triple board certified by the American Board of Internal Medicine, the American Society of Hypertension, and the American Board of Anti-Aging and Regenerative Medicine. He has a master's degree in human nutrition and a bunch of other things. He has presented over 10,000 lectures nationally and internationally, published more than 200 articles. He has written a bunch of books, including this one, which we're talking about today, What Your Doctor May Not Tell You About Heart Disease. So, Dr. Houston, thank you so much for joining me.
It's a pleasure to be with you. Thank you so very much.
And we're going super high-tech over here, passing the mic back and
I'll
forth.
let you pass it back and forth. You're good at it.
Okay. All right. So, first of all, how did you get into cardiology?
I started my training at the University of California in San Francisco with some of the best in the world, Kanu Chatterjee and Mel Shitlin. And then when I came to Vanderbilt, I trained under some incredible cardiovascular medicine folks. So I started into hypertension as a specialty when it was offered in 2000, and then developed interest in cardiovascular risk factors, looking at dyslipidemia in a different way and other cardiometabolic risk factors. So my practice really now is an integrative cardiovascular medicine prevention program where I try to keep you out of the hands of the cardiothoracic surgeons and keep you out of the hands of the folks that do interventional cardiology with bypass graft and stents and the PCTAs.
So I've seen Mark Houston present before at medical conferences, and he really knows his stuff. And most of what he talks about now is how nutrition, or a lot of what you talk about, is how nutrition can help in cardiovascular health. And I just assumed that you'd always been into nutrition, but I found out recently that you haven't always used supplements and nutrition in heart health. So can you tell us a little bit more about how you got into that?
I'm actually kind of a newbie. I came out of the dark ages, with Darth Vader and saw the light. And so I started about 15, maybe 20 years ago looking at cardiovascular integrated medicine and nutrition. Knew nothing about it because I trained as a traditional MD. So about 1999, 2000, I went back and got a master's degree in human nutrition from the University of Bridgeport in Connecticut. And that was my first ability to have what we call credentials in certification, as opposed to having apples and oranges thrown at you from the back of the room because you didn't know what you were talking about. And then I went on to get further metabolic medicine training at USF. So right now, when I treat patients, it's really integrated. I use drugs, obviously, but I try to keep people off drugs if I can, to do a lifestyle change, good nutrition, and nutritional supplements.
Very nice. And can you tell us a little bit more about your practice here at St. Thomas?
Yes. I'm in a big group here. It's the St. Thomas Medical Group. We have 38 physicians that I work with. But I'm the only one here that really does hypertension and cardiovascular prevention. And the Hypertension Institute, which is really more of a cardiovascular institute, we started here in 1995 at St. Thomas. And we have a very good internet site. If you want to look it up, it's hypertensioninstitute.com, very easy to find. And it's a lot of free protocols, information on there that is good for patients, but it's also good for physicians. So the practice has developed into really a global practice. We have people come from all over the world here to get really a 3-day program. And we do testing that's available really nowhere else in the world. We have different non-invasive tests. We also have invasive tests if necessary. And when a patient leaves here after a 3-day workup, we have a pretty good idea of their nutritional status, their biological age, their cardiovascular status, their heart, their carotid arteries, their brain, a lot of things. Even we do telomere testing. We do all the things that really are advanced testing in lipids, blood pressure, 24-hour monitoring. And so you really have an understanding of your cardiovascular profile when you leave here, and we tell you exactly what to do to prevent further problems.
And we'll get into the testing a little bit more later on in the show. But my show is focused on women's health. And I know that heart disease is a big risk factor, a big problem for women. Can you tell us a little bit more about the statistics about that and why it becomes a problem, especially as women get older?
Certainly. Women have different symptoms that they present with from men. So they're often misdiagnosed or they're missed. For example, men typically present with substernal chest pain when they're exerting themselves. Women often may have just shortness of breath. They may have just fatigue or something different. So they're diagnosed later. Their disease tends to be more severe when they're diagnosed. And the test actually, there's a lot of what are called false positives and false negatives, which means you can do a test and the test will show a positive result, but they don't have the disease. Or you can do the test, it shows a negative result, but when you do a further test, it shows they really do have the disease. So women are hard to diagnose. Their treatment is a little bit different as well because they don't necessarily respond to the same drugs. There's differences in the hormone levels, obviously, which have a huge impact on clinical symptoms as well.
My hands are turning more and more blue, I feel like, so I might have you hold the mic in a little bit. So most doctors focus on the big 5 risk factors, which are elevated cholesterol, specifically LDL, or what they call the bad cholesterol, high blood pressure, diabetes, obesity, and smoking. But you say that that's misleading because it doesn't actually, or those don't address the real cause of heart disease. Can you talk a little bit more about that?
Yeah, what has happened over the past 25, 30 years when the risk factor analysis has been promulgated by different cardiovascular committees is each year it's always the same story. It's blood pressure, it's cholesterol, it's dysglycemia or diabetes, it's obesity and smoking. Never anything beyond that. And when you bring out a new risk factor which has good data, a lot of people they don't believe it. They don't think it's true. But I went in and looked at this and we found really 395 other risk factors for coronary heart disease that are really ignored. Mm-hmm. And we broke it down into really a pathologic mechanism so that you have a myriad of insults that attack the artery, but there's only 3 ways the artery can respond to those insults. It's inflammation, oxidative stress, and immune dysfunction. And if you understand that, the treatment becomes very basic and much more simplified, and you can then start using a prevention program that allows the patient to address the underlying problems of their vascular disease, and it will promote their vascular health. The other problem is all the 5 risk factors have been misdefined. One example is the lipid hypothesis. Most physicians still use total profiles of their lipids, so they'll measure total LDL, total cholesterol, total HDL. You cannot determine risk using total levels, and you cannot determine adequate treatment. You have to do advanced lipid testing. And advanced lipid testing allows you to look at what's called particle size, particle number of both of those, as well as the VLDL, which is triglycerides, but also look at the function of the HDL, which is like the cleanup crew. So if your HDL is not working, I use the garbage truck analogy. You probably heard me say this. Can I do this? This is good. Yeah. Okay, with the garbage truck analogy for the folks. So if you have a big garbage can or several garbage cans in your backyard and they're full of garbage, that's LDL cholesterol. That's the bad stuff. Okay, and you have your garbage collector who comes in and picks it up. And he comes in with this huge truck that can carry off all the garbage cans at one time. He's got some very nice motor, a lot of horsepower, and nice wheels, no flats. Okay, takes it away, no problem. That's reverse cholesterol transport. That's the HDL. So the HDL is the truck, and the garbage is the LDL. Now, I suppose you have another guy who comes in, he's got a tiny little truck. But he's got some good tires, good horsepower. He'll only take one garbage can out at a time. So he has to keep drip back and forth, back and forth. That's okay, but it takes a while. It's not very efficient reverse cholesterol transport. The third guy comes in, he's got a really huge truck, but he's got 4 flat tires. He's not going to get anything out of there. So that's the dysfunctional HDL. It looks pretty, doesn't work. So you have to start measuring all these things. So we have to do advanced lipid testing to really determine the functionality and the size of the particles. No one's really doing that except people that are really knowledgeable about lipid disorders. And we do that for the other things too. We do it for blood pressure with 24-hour blood pressure monitoring. We do it for new diagnosis of dysglycemia and diabetes with testing that is way beyond before your blood sugar goes up. Because by the time your blood sugar's gone up, you've already lost at least half of your beta cell functioning pancreas.
So with some of this testing that you're talking about, if someone's listening or watching and they want to get some of these tests done, where would you send them to?
Well, there are a lot of centers in different places that have some of the tests, but unfortunately even some of the large academic centers don't have all of the tests, or they don't have a specialist perhaps that really believes in the new concepts of cardiovascular disease. Now, we're glad to see anybody here in the Hypertension Institute that wants to come, and we have a very efficient process by which we can do that. And people don't have to keep coming back and forth. It's one visit, maybe 2, and we handle things by the phone or by email. So it becomes easier now because of the technology involved, whereas before it was difficult. Mm-hmm. So anybody can access a good care. It's not cheap sometimes. Insurance may or may not cover a lot of the tests. But if you really want to get to the root of the problem and get it treated and have a better quality of life and less risk for a heart attack or a stroke, it's important to do it early. It's never too late, though, to have the testing done to make sure you're treated correctly.
So in your book, I'm just going to quote this. You said, "For years we believed that heart disease began with atherosclerosis or clogged arteries, a process initiated when excess cholesterol and fat in the bloodstream stuck to the inner lining of an artery, more and more stuck, and eventually blocked the flow of blood in an artery supplying the heart, triggering a heart attack. That idea is now obsolete." Let that sink in for a moment. So how does a heart attack actually happen if it's not like that? Because that's what we all picture.
Right. So in the United States and most Western countries, the cholesterol-centric approach has been the paradigm for how heart disease occurs. And what people don't understand is cholesterol is a normal constituent of the blood. You have to have cholesterol. And native cholesterol, or LDL, is not even atherogenic. If it were, your body would reject it. It has to be altered in some way before it causes problems. It's the alteration of the LDL, and then 38 steps from the time it's altered before it actually gets to the part where it causes a plaque. Well, it's a lot more than cholesterol then, obviously. And there are other factors that are part of this called the LDL modification process. And what is the downstream effect of the changes in the lipids is inflammation. So inflammation and the things I just mentioned, oxidative stress and immune dysfunction, are the downstream effects of the lipid hypothesis. And so we've been totally misdirected by looking just at lipids and not even addressing the pathology, the 38 different mechanisms by which you even get there. And that even ignores the fact that we've not defined it correctly and we don't have the other risk factors defined correctly.
So, you guys like this fancy mic thing we have going? So if someone doesn't have high blood pressure or high cholesterol, they could still have cardiovascular issues, right? Can you tell a little bit more about that?
Yeah, the problem in, for example, if you went to your physician and he ordered a traditional lipid profile and he said to you, your LDL is 100, and that's normal by guidelines, and he would say to you, and your HDL is 80, and he would say to you, look, you have not only good risk, you have below average risk. Therefore, based on my lipid analysis, you have no risk for coronary heart disease. Now, if you came to see me with those numbers, you know what I would say to you? I have no clue. I have no idea whether that's your LDL is bad. I I have no idea whether your HDL is good. So I've got to do some other tests before I, number one, know that you're at risk or not at risk. And number two, do I even need to do anything about it? So I do an advanced lipid testing. I would check to see the particle size and numbers, and I would check and see if your HDL is functional. Then I can tell you what to do. So when someone tells you their total level is normal, their LDL is normal, my response is it's worthless information. You don't know.
It's very interesting. I want to go back to the three big things that you talked about: inflammation, oxidative stress, and the immune part. Can you just explain those three a little bit more?
Absolutely. Inflammation is a response to the modification of your LDL. For example, if you have a foreign substance invade your body, the body responds correctly to that response that's coming in. It's an invader. Tries to get rid of it, tries to contain it. So the body's not doing anything stupid. The body has a very high IQ. It says, okay, I've got a foreign invader, bacteria, heavy metal, gluten, whatever, and I've got to contain it, because I don't, it's going to cause disease. It's going to cause vascular disease. So the response to that is inflammatory. The response to that is oxidative stress and immune dysfunction. So you have T cells and B cells as part of your immune system that attack the invading whatever, whether it's a bacteria, virus, heavy metal, whatever, and contains it and tries to excrete it, get rid of it, usually through the liver, sometimes through the urinary tract and the kidney. It just depends. Sometimes it can't get rid of it. It just contains it, and it gets deposited. Guess where it goes? To fat tissue. So one of the great sayings, is not mine, someone else's, the solution to pollution is dilution, which means if you're a polluted individual, a lot of pesticides and organocides, it's going to go to fat tissue, and you tend to gain weight to try to dilute the pesticides and organocides. So one of the concepts is obesity, and even diabetes for that matter, are toxic diseases from our environment. Mm-hmm. And if you remove the toxins, the fat starts to go away.
And I was actually asked this by someone else. Is there an autoimmune connection as well?
Yes.
Can you explain that?
Yeah, the autoimmune connection is this. You have, let's just say it's a virus that attacks. The body mounts the responses, which is B cells and T cells, which are part of the immune system, to contain the infection. And let's say that works, but you keep bombarding the system over and over and over again with the same virus. So it's a chronic viral infection now. So the body keeps mounting a response every time that happens. What happens eventually is there are proteins on viruses and bacteria that are identical to proteins in our cells. And the immune system, although it's pretty smart, sometimes it can't recognize a foreign invader versus an innate protein, and it cross-reacts. So now it's attacking not just the virus that came in, it's also attacking your own system. And it can attack anything. But if it attacks the vascular system, you get vascular disease, and you start getting atherosclerosis as part of an autoimmune system. So a lot of people looking at vascular disease now realize vascular disease, vascular biology, atherosclerosis is an autoimmune disease.
Wow.
Mm-hmm.
So that's a lot of, doomsday information, but at least we kind of have a basis. But in your book, you actually outline your 8-step integrative cardiovascular disease prevention program. Can you kind of review that in not as many pages as it was in your book?
I'm going to condense 80 pages into 8 seconds. There, very good. Okay, I'll do that. So one of the key things is to realize there's a lot of research that says if you did 4 or 5 things, you could reduce cardiovascular disease by 80%.
Wow.
Okay? So number one is proper nutrition. And that's basically at least 10 to 12 servings of proper, organic, relatively raw fruits and vegetables per day with high-quality protein, that sort of thing. Number 2 is optimal exercise, which is both resistance training but also aerobic training. We recommend that you do resistance training first for 40 minutes and then 20 minutes of interval aerobics afterwards, at least 4 days a week. Okay? And then you get all the wonderful anti-inflammatory effects and things that muscles make that reduce cardiovascular disease. You have to have good sleeping patterns, at least 8 hours a night. Too little or too much is not good. You have to have a relaxed lifestyle. You can't be stressed all the time. And you have to take nutraceutical supplements because our food supply is so horrific. Unless you grow your own and it's organic, it's very hard to get high quality, high nutritive foods at this point. And there are a lot of things that aren't even in the foods anyway. So nutritional supplements, in my opinion, are key to supporting health, not just cardiovascular, but any type of health. So we have to do all those things. And then there's a lot of things related to relationships. People that are constantly antagonized about things. They're always sympathetically driven. They don't have a good parasympathetic tone. That increases their blood pressure and their heart rate, risk of heart attack, plaque rupture, thrombosis, clotting, all those things. So those are the basic things that we tell people they really have to do, and they're not expensive. They're things that everybody can do. No drugs.
It always goes back to the basics: eat real food, relax, be happy, all that good stuff.
Laugh a lot and smile.
Yes. I have a few questions. First, on the diet. So, in your book, you did recommend a little less saturated fat, but from my understanding, our understanding from the research on saturated fat has changed. So, can you talk a little bit more about that?
The whole fat story is very controversial. I'll tell you what is pretty clear that I believe is correct. All omega-3 fatty acids are good, no matter what you say. Despite some of the studies that say they're not, those are bad studies. So omega-3s absolutely should be part of your diet. All monounsaturated fats, which would basically be things like olive oil products, olive oil, and nuts, very healthy. The Mediterranean diet classically showed that is very good. Extra virgin olive oil and nuts reduce heart disease by enormous amounts, like 35-40%. Very important. Those two, no question. Trans fats, bad, no matter how you cut them. Get those out of your diet. And most countries, states, whatever, getting them out now in all the foods. The one that's controversial are saturated fats. There's a balance. You have to have some saturated fats. If you don't, you have an increased risk of ischemic stroke. The Japanese, for example, don't eat a lot of saturated fats, on the highest risk of ischemic strokes in the country. Hemorrhagic strokes. And so there are certain saturated fats that are good and some probably that are not. And that's where we're getting all kinds of arguments. What is it about the saturated fat? Is it the carbon length, C12, 14, 16, 18? How long is the fatty acid? What does it do to the endothelium? What does it do to arterial health? It's not so much about what the fats do to lipids, because that story is kind of old. It's really more what they do to the vascular health. So I tell people saturated fats in modest doses. When I say modest, I'm talking maybe 10% or less of your total fat content is probably fine, but don't overdo it. But you need some.
Okay. Yeah. All right. I'd love to get your take on this. I know I already have, blue hands, but I also have really high iron levels.
Oh.
Yes. And I do have one of the genetic mutations for hemochromatosis, which is just basically iron overload. But my ferritin is normal. My iron saturation is up and down, but it's been really high at times. But I remember when I first found this out, I was going to my doctor's a couple of years ago, and he said, "Oh, you don't have to worry about this." I even spoke to one of the iron experts at Kaiser, and he said, "You don't have to worry about it." And I said, "You're telling me that I don't have to worry about it until I'm in my 40s or 50s?" So I was just wondering, if there are things I can do, if I should be avoiding it more in food, so I don't get heart disease.
Okay. You're clearly of European origin. Because hemochromatosis is usually from northern European countries. Probably Belgium, somewhere like that, probably. Likely.
Western Europe?
Mm-hmm. Yeah. Okay. All right, so hemochromatosis, heterozygote, which is what you are, half the gene, not a homozygote, is an increased risk for iron absorption. Iron's not a good thing if it's too high. It's a catalyst for oxidative stress. So it increases oxidative stress and radical oxidation species, just like copper can. Those two can do the same thing. And so But the other thing iron does is it oxidizes LDL cholesterol and makes it foreign protein, or foreign lipid, I should say, which increases atherogenesis. So if you have hemochromatosis, you have increased inflammation, increased oxidative stress, increased immune dysfunction, increased risk for cardiovascular disease, increased risk for diabetes, metabolic syndrome, insulin resistance, and a lot of other things. So you don't want an elevated iron. I try to keep iron at a level lower in men even than women, because men have more CVD anyway. So the ferritin is the storage form. So I tend to measure both the ferritin as well as the total iron content and the iron binding capacity, and try to figure out what the ratios are as well as the total levels, and get them to a safer range. Yeah. But it is
So should I be avoiding it in food?
You need, well, if your iron is elevated now, you need to have phlebotomies to get rid of it, keep it under control. You don't want to ever take a supplement unless it gets deficient. And you do have to watch high iron-containing foods, because they do increase the levels over time. But if you do that, sometimes you negate other good nutrients that you get in those foods as well. So I tell people to watch it, but I'd rather you eat well, and then I'll get the iron out some other way.
All right.
Makes your day, huh?
It just sucks because steak with, spinach and a glass of red wine is kind of an awesome meal, but red wine also increases
We'll
iron
send
absorption.
you the Red Cross every month, okay?
I can't, because I'm from Belgium and I lived there during mad cow's disease. It's a long story. We've spent a whole day together, so this is why we're a little loopy right now. So you talked about the importance of nutritional supplements. Can you tell us, what are some nutrients that we should consider taking?
I think the most important, if you look at the literature, is omega-3 fatty acids. Everybody should be on those. There's virtually no contraindications to that. Coenzyme Q10 tends to drop off dramatically in older people. If you exercise a lot, certain drugs deplete it, so that's very important in energy production, electron transport chain, and all that. But there's so many out there that are important. I mean, you could talk about all of them and say that these are all important. So what I try to do is get people to take a very balanced nutritional program, and we measure things. That's the key. Mm-hmm. We actually measure the nutritional analysis in their lymphocytes, and we can determine what their average nutritional content is over the previous 6 months.
Is that with the SpectraCell?
That's the SpectraCell micronutrient test. And you replete what's missing. And then you put them on a good maintenance program. And I will tell you, having done this for 15 years now, people who do this, they don't have fatigue. They don't have as many respiratory tract infections. They think clearer. They don't tend to lose their memory. And they have less chronic disease. So I know it works. I've seen it works. It's not anecdotal. And I have patients that don't end up in the hospital. They stay healthy. So my hospitalization is very low compared to a lot of the patients that are seen by other doctors who don't do the prevention program.
Very interesting. So you talked about blood sugar before. I think I remember reading in your book, normal blood sugar, the lab reference range is like 80 to 100. But I think you said starting at 80, it increases your risk.
Close,
yeah. Can you talk a little bit more about that?
Most labs use, as you said, around 99 is the upper limit. So if you go to 100, you're already sort of defined as dysglycemic. But if you're at 100, you're already really sick, because the actual risk for, I would call dysglycemic-induced vascular disease starts at 75 milligram percent or deciliter fasting. So if you're at 100, you're already 25 points higher than you should be. It's a 1-to-1 correlation, meaning that 1 milligram per deciliter increase in fasting blood sugar increases your risk for coronary heart disease and myocardial infarction by 1%. That's 25% if you're at 100, which most doctors would say, don't worry about that, you're normal. You're not. Now, the other thing is that fasting blood sugar is only part of the dysglycemic response. You've got to look at what happens after you eat. Every time you eat, unfortunately, you get atherosclerosis. So here's the bottom line. You're not going to like this one either. Atherosclerosis is a postprandial disease, meaning that atherosclerosis occurs every time you eat because you cause what's called metabolic endotoxemia. You take not only the bad nutrients across the intestinal barrier, but you take live and dead bacteria as well. And the body responds to those three finite responses, so you get this horrible endothelial dysfunction. It leads to vascular dysfunction. Every time you eat, you're doing one of these things. Well, let's say your blood sugar goes to 150 after you eat. Now, that's not normal. It should be very well contained. So if you do one of these great glucose tolerance tests, where you drink the nasty glucose, and you check your blood every 2 hours, at 2 hours, the lab says, it's got to be less than 140. That's the normal by the lab. It's actually 110. That's a 30-point difference, okay? So which is true. It turns out if you're 140, your risk is 2 times greater for each milligram percent. So if you go from 110 to 140, it's a difference of 30. 30 times 2, now you're at 60% increased risk for a heart attack at what the lab says is normal, even though it's not normal. So those are clear. And then there's other parameters we use that back you up even further, like insulin and proinsulin and C-peptide that define disease even before the blood sugar becomes abnormal.
So why do traditional cardiologists and doctors, why haven't they caught up with the research? And what are you doing about it?
I'm out pounding the pavement trying to get the message out. Honestly, I think a lot of it is the way we were trained. I mean, I was trained the same way. The medical schools didn't address nutrition very well. Certainly nothing about supplements. So we didn't know anything about it. I had to learn it all after I got out of medical school, after I did my training. And if you don't go back and take another course and you're not motivated to do so, you believe everything that's in the traditional literature, which is it's not very favorable actually to nutritional supplements at all. There's a lot of unfortunate agendas and research that takes things in a direction that look bad when the studies themselves are actually bad, not the supplements and not the nutritional things that they're studying at all. But the only way to get the message out is people have to be open-minded about things. They've got to realize that just because they learned something 15 or 20 years ago, it's not necessarily correct now, and that nutrition is very important, supplements are important, have an open mind, go read about it, go to a conference and learn about it, and come back and understand that there's more to this than what you've been taught, and more to it than just taking a drug.
Mm-hmm. So for the women or men listening to the show, what's something that you'd like to leave them with?
Well, I'd love to leave them with a lot of things, but let's see if we can condense it for you. I think the most important thing is to be proactive in your health and realize that no one is going to make it better until you decide to make it better. You can go to somebody and tell you what to do, but you're the only one that's going to be able to do it. But you've got to go to someone who believes in good health and knows what to do to define it and how to treat it. And so you've got to, number one, believe it, find someone that can help you do it, and then carry out the mission. We know what to do. It's just a matter of you doing it.
That's always the hard part. All right. Thank you so much, Dr. Houston. It was. You're welcome. It was fun.
Come back again. Your hands warmer.
Okay. Thank you guys so much for listening, for watching. You can find more information about Mark at hypertensioninstitute.com.
Right.
And you can also read his book. He also has another book about hypertension. Do you want to grab it? Because it's right there.
There we go.
So
side-to-side paired books, dueling.
So
agent.
great information. Mark, thank you again so much. Thank you for watching.
Thank you. Okay.
And check out the website, elevate-your-energy.com. Thank you.
Are you having green tea there?
No, I was actually just going to say that in Belgium we have the best beer and the best chocolate and the best fries.
Well,
It's been a long day, ladies and gentlemen. All right, are we... How does the sound? How does the sound
are we?
Like Shrek?
Hey, I don't know where you've been or what you've been doing, my dear, but I'm glad you won the first prize.
How about a little Irish? I can't do Irish or Scottish.